Welcome everyone again. I am just putting once again that brief survey in the chat for those of us who weren't here prior and can't see it. So today I have the great pleasure of introducing Dr. Kamran Mirza. He is a professor of pathology at Michigan Medicine, where he serves as the Godfrey Stobbe Professor of Pathology Education, Assistant Chair for Education, and Director of the Division of Training Programs and Communication. He has had so many awards. We would be here all meeting if I tried to list off all the awards he's gotten for both as a pathologist and as an educator. And so part of that, Dr. Mirza has really revolutionized the social media use for pathology education, including co-founding this particular group, our virtual pathology student interest group, as well as the Path Elective. For those who haven't checked out that website, that's a great resource. He's also part of the PathPod podcast, Digital Communications Fellowship in Pathology, and the International Collaborative of Pathologists. His excitement for pathology is what actually first piqued my interest in this field and has now led me, to apply and start my interviews here in a short little bit. So I cannot think of anyone better to introduce all of you to this amazing specialty. And so with that, I'll hand over the reins to Dr. Mirza.
Thank you so much, Rasa. I mean, honestly, like if you think about any introduction, like what better introduction than the fact that I could have played a small role in you choosing pathology? That is more than enough introduction for me. That's fantastic. So, good evening, everyone. If it's the evening for you guys, it's wonderful to be chatting with you about pathology, my most favorite subject in the world of medicine. And it's kind of a nice small group of people. And so I think what we'll do is that I'll go through some slides, but I really want this to be interactive. And so I'm on my laptop, so I can't see the chat when I'm presenting, but I will certainly unshare at some point really quick, and then we can chat. And feel free. I mean, I understand it's the evening, so you guys must be busy. So if you want to stay muted with your cameras off, no problem. But if you did want at that point to kind of unmute and open up cameras, it would be wonderful to have a conversation. So with that said, let's talk about pathology, the unseen and the indispensable. I think that this has always been kind of like my little tagline for pathology. Over the course of the next hour, you will hear some more taglines from me as well. I would love for you all to be able to consider pathology. And, it's not my goal for you to want to all become pathologists, although that would be wonderful. But my goal is for you all to know that this is a really incredible branch of medicine and that we are physicians who have gone through medical school and residency that end up doing this field. There's a lot of misconceptions about pathology. And so today we will hopefully get rid of all of those misconceptions for you. And you may end up deciding that you don't want to do pathology, and that's totally okay, but at least you'll be making an informed decision, right? And so that's the important thing that I would like you all to be considering. So I want to start off by thinking about, let's say we have a 7-year-old boy, and he comes to his parents and he has a fever, and they go to the pediatrician, and the pediatrician is like, all right, we need to start working this, kid up. Like, is it an infection? And they make a blood smear. And so who is the person who will tell that pediatrician whether that fever is because of a leukemia or whether it's because of an infection? Now, you might think that this is kind of an esoteric scenario. It's not. Kids can present with fevers and they have leukemia, and kids can present with fevers and they have infection, right? And so while there will be lots of different signs and symptoms that the pediatricians will be picking up on, the final answer comes from the laboratory. It comes from a pathologist. It comes from reviewing the cells. And without that, no one is going to start treating for chemo, and no one is going to start treating with antibiotics. So pathology holds an immense, and I would say august kind of power. And what I realized about pathology kind of late in medical school, this wasn't on my radar, was that we are affecting every different aspect of patient care, right? And I think that's very, very relevant to think about. All right, the QR code takes you to my link tree, so you can, follow me along if you want. But let's talk about the typical misconception. So if you I have already decided about pathology and you're telling your other folks about pathology, they'll be like, oh, but you're too social for pathology. That's a classic one, right? And if you say you're a pathologist, it might be that they think that your communication skills must be poor. And I have to tell you that that couldn't be furthest from the truth, because literally no one else in the whole hospital needs better communication skills than pathologists. I mean, can you imagine finding out from a poorly communicative pathologist that your loved one has cancer? Like literally, communication is like number one for us. Right? They'll be thinking that we're in the basement, and they will probably ask you whether you like dead things, right? And so these are all kind of misconceptions. And so, this is Cole. He's standing there doing surgery and looking at the camera. Cole and I wrote a piece a few years ago for the Pathologist magazine. Cole is a resident now in the army, and I think he's about to do neuropathology. But Cole and I wrote this paper called "But You're So Good with Patients," and the usual taglines are, "Oh no, they'll cry," and "But you're so good with patients," and "What's the point of doing things once they're dead?" And "Don't bother teaching that student; they want to go into pathology." So you will not be the first people who have been faced with this. And so I always ask people how they came across pathology, and the usual answers are that they happened to do a pathology elective. It was, serendipity for them. They were just trying to fill up their schedule. They had no idea what this is. Some of you may have been working in a lab. Some of you might have family or loved ones that are pathologists, and that's why they know about the laboratory. So pathology in that sense is everywhere, but it's also nowhere, because in the medical school curriculum, Rasa is very familiar with this. I've written Mechanisms of Human Disease. The courses for pathology are even not known as pathology anymore. Like they're kind of hidden. A lot of you might have step one PTSD, thinking about, step one and kind of getting to pass it. And pathology is a huge part of step one. So, you don't want that PTSD to be associated with pathology. And then this idea that clinical medicine does not include pathology is so wrong. And pathologists do this all the time when they say, oh, clinical correlation is recommended. Bro, we can do the clinical correlation. We are physicians. So it's a clinical specialty, okay? It's not a basic science. But what happens is that it's taught in the basic sciences. And effectively right now, as many of you, at least if you are joining from the United States, know that they've shortened the preclinical curriculum, and as pathology was part of the preclinical curriculum, it has also been shortened. And the idea is that they want to improve the delivery of higher quality, higher value, and lower cost medical care, and they want to train in operations management and process improvement. And that's really interesting, because process improvement and operations management is something pathologists do really, really well. And it's ironic that at the same time, we will be getting less time in the curriculum. All right. So the preclinical training has been reduced to no more than 15 months for most of you. And there's no concept usually of thinking about pathology in a vertical way, right? So the vertical curriculum, typically, when you think about it, people think about radiology and other things, and there are implications for pathology, for you to think about pathology, and to those who are becoming pathologists. The other thing that has happened, and all of you are probably familiar with this now, is that there's a change to pass fail for step one. And I'm not sure if this has helped pathology or harmed it, right? Because a lot of people were studying pathology because it was a step one requirement. But now we're not sure whether this is going to affect you or not, right? And so do we have a recruitment problem, right? And how do we correct it? And so Dr. Zafar and Dr. Bacon wrote this article in the Pathologist magazine. And the point that they wanted to make was that if students don't have the opportunity to interact with pathologists in a clinical setting, we graduate physicians who lack a full understanding of the role of the pathologist on the patient care team. And the reason for that is because you're not seeing us as physicians, you're seeing us as teachers, right? Primarily. The other thing that, so Austin is now an attending, I believe, at Stanford, but he was a medical student with like where Rasa is at Loyola, where I used to teach before. And Austin and I wrote this paper called Dissecting Brain from Brawn, where what we wrote was that when choosing a medical specialty, many students are leaning towards like flashier or more popular fields of study, and pathology in many cases is lesser known, and many students never truly learn what we do. And so we must introduce all students to pathology as a specialty. And what we meant by brain versus brawn was that a lot of people who want to do surgery actually don't realize that they actually might want to be diagnosticians, and they want to do pathology, right? And so this was a little tongue in cheek about brain versus brawn. So then the case of the universal clerkship, that's Austin and me sitting in my Loyola office. But basically the idea was that we need to create a checkbox for pathology, and that, when you enter medical school, everyone has different things to check off or on, right? So for example, on your lists, you'll have, oh, do I want to become a surgeon, or do I want to become a urologist? Do I want to become an anesthesiologist? Do I want to become a psychiatrist? But you won't have pathology on the spectrum, and you need to have that checkbox. And then if you want, after you've had the experience, you can check it off and say no, or you can check it in and say, yes, that is what I want to do. I love this tweet that Cullen, who is the chief resident at UCLA and one of my mentees, extraordinaire, put out a couple of years ago when he was about to go into the match. And usually this was also because usually when we think about, oh, a guide to choosing specialties, they never have pathology. They typically have an arm which says, oh, if you like dead things, you can become a pathologist. And basically that's BS. And so I love how he basically put pathology in every single one of them, right? That if you like histology, sure, you can become a pathologist. But if you like anatomy, you can become a pathologist. If you like radiology, you can become a pathologist. If you like embryology, you can become a pathologist no matter what you like, right? So I love this because I really do think it's truthful. And I was a medical student who loved every single thing. And so we need to check that box. So it is truly a clinical specialty. We are making clinical decisions that affect the patient. We are doing it behind the laboratory curtain. So the patients may not know what we are doing, but basically, if you go into the clinical parts of the laboratory, you will see that they are all patient care, right? And so I am a clinical professor of pathology. I'm not a research professor. I am very much using my MD degree and my residency and fellowship training. So shout out to PathSeg. I'm so proud of this group, right? I'm one of the founders of PathSeg. I know Rasa's on the leadership team. I'm sure other people from the leadership team might be here already as well. But I'm really, really proud of the work that PathSeg is doing, because what we've realized is that your local or institutional pathology interest groups wax and wane, because some years you'll have a lot of interest, and there will naturally be some years where you don't have that much interest, and PathSeg is here to fill that gap. And so I'm really proud of this work. And so I hope that you all follow PathSeg if you don't already. Path Elective, Rasa mentioned, this is a website that we created a couple of years ago now. It has like 250,000 users, like more than like 3 million page views. It's a totally free pathology elective that you can kind of use as a supplement to your in-person electives. And the idea is that you just go to pathelective.com and you register. I promise we never send you any spam mail. And hopefully going to be a useful resource for you. So when we think of pathology and when people talk about generalizations, you think about forensics more than anything. And then you think about like these tongue-in-cheek comments that pathologists will say, funny looking cells in pink and violet correlate clinically. This is not true. Forensics is a very important part of pathology, but it's just one part of pathology. And we sometimes do say correlate clinically, but that's typically when we don't have the clinical information. And for those of you who think of pathology as synonymous with Robbins and Cotran's pathologic basis of disease, we are more than just your M2 learning. And for those of you who think about it as pathoma, I love Hussein Sattar. I trained at the University of Chicago, so I have nothing but love for him. He is incredible and he's amazing, and pathoma is amazing. But being a pathologist is more than studying pathology, right? So in fact, if you think about a group of people, if you think about a group of individuals, every single person, their life is being touched by pathology, right? So from the cradle to the grave, the first beta HCG test that somebody takes is a pathology lab value. And after they die, the autopsy that they have is also a lab value. And I recently wrote a paper which should be coming out in The Pathologist, I think this month. And that is that, typically pathology either isn't thought of as a medical specialty, but then when you do know it's a medical specialty, they think of it as a very subspecialized specialty, which is true. We are very subspecialized, but we're also primary care, right? Because without us, without the laboratory, there's no primary care, right? There's no CBCs, there's no monitoring, there's no screening. All of the things that you think about in primary care, there's nothing without pathology, right? So whether it be a urine test, whether it be a PSA value, whether it be an ovarian biopsy, whether it be a blood smear, whether it be phlebotomy, whether it be next-gen sequencing, all of it is being done in the pathology space. So I thought that, in our time together, for those of you who may not be familiar with pathology, we can think about the journey of a specimen. And so let's imagine that there's a patient who comes into the emergency room. and they're obtunded, so they can't give any history. And so really the physicians in the ER will, or the nurses, or the healthcare providers will basically be trying to figure out what's happened to the patient using diagnostic stuff, right? So they'll be imaging and they'll be testing, right? And so if you think about the myriad of tests that will be in the EPIC chart, right? It could be a CBC, it could be a CMP, a BUN, a creatinine. We need to check their electrolytes, the drug levels, tox screen, LFTs, thyroid function tests. All of these are pathology. Okay, every single one of these are pathology, and you can actually become a specialist in clinical chemistry. You can become a specialist in hematology. And so they say that in your electronic health record, 70% of all clinical decisions are being made from pathology values, right? So let's say that, your patient comes to clinic and he's Mr. Smith and he's 64 years old and he has a past medical history of diabetes, chronic kidney disease. He has a 30-pack year history of smoking and COPD and had colon cancer, which was resected 10 years ago. So now the question is, what's going on with him? He has a prominent neck node, which is palpable. And so the question is, what do we do, right? Do we just treat him for metastatic colonic cancer? No one does that, bro. You have to do a biopsy. Without tissue, nothing is going to happen. Okay. So the pathology world is split into anatomic and clinical pathology. This is very much an American way of looking at it. So if you were from outside the United States, pathology is thought about a little bit differently elsewhere. But in the US, we have AP and CP. And so because it's a palpable lymph node, we potentially can, kind of tease it out by just putting a needle in it. So that is the arm of AP called cytopathology. And cytopathologists can sometimes do these procedures themselves, whether it's ultrasound guided or not. They take a syringe. And, in our training, we've actually also kind of learned how to do these FNAs. And you can take anything that is palpable and you can pull out some cells and take a look at them. And it's a really incredibly powerful tool to be able to kind of look at what's going on. So usually this is lesions in the neck, palpable lymph node, lesions in the breast, anything that is accessible to palpation. Right. And so cytology is an incredible arm of pathology. And like, for example, for many people who get screenings, pap smears are cytology. And so cytologists are incredible pathologists. So let's say that the cytology, we tried it and imaging was showing that there's a left upper lobe spiculated cavitary nodule. PET shows that it's got increased SUV. There's also prominent hilar adenopathy. We tried to do the lung nodule by FNA, but it didn't work. So we recommended that there be a wedge biopsy. So the tissue will now come to surgical pathology, right? In other parts of the world, it might be known as histopathology, but it comes to surgical pathology. And when you go to surgical pathology, it's through surgery that we receive this biopsy specimen, right? And so first, we will get potentially a frozen section. This is a quick turnaround where we freeze the tissue and we make a slide and we take a look at it and say what's going on with the patient. It can have hugely important decisions for what will happen with the surgery, whether they will continue the surgery, whether they will change the surgery, etc. And so at that point, it's found that within 20 minutes, we tell the surgeons that it is likely adenocarcinoma. And, even this is made fun of here. This is a tongue-in-cheek kind of thing that came out many years ago. Surgeon sends lunch for frozen section. After visiting the hospital's cafeteria, Dr. Green seated himself in the surgery staff to enjoy his lunch. And after a few bites said, I'm going to, I ordered fish sticks, but, this doesn't feel like fish. And so let's send it for a frozen section. So people make pathology, like fun of pathology all the time, but it couldn't be furthest from the truth. So here, let's say is a wedge resection of the lung. We can tell the margins. We can fix this tissue. We can say the size of the tumor. Like we literally will be looking at the tumor. Okay. So everyone else is just guessing. We will be literally kind of the staging of the tumor will be very dependent on what we kind of find. And so the permanent sections will be fixed. They'll be dehydrated. They'll be embedded in a paraffin block. They will be cut by histotechnologists, and then the sections will be looked at. And then the sections can also have special stains. So here, this is an adenocarcinoma. It's an acinar type. It's measuring 3.5 centimeters in greatest dimension. It has negative margins. The background lung has emphysema. There are 10 lymph nodes that are negative for malignancy. So the pathologic stage is T2A and 0. And there's a stain for TTF1. And so we've confirmed that this is primary pulmonary adenocarcinoma and that this isn't a metastatic lesion from the colon cancer from 10 years ago. And so this is very important in their staging. It's also important in molecular. I don't talk about molecular today, but we could have a whole session on molecular, whether it be the molecular underpinnings of hematopoietic diseases or the molecular underpinnings of personalizing cancer treatments in any solid organ, including the lung. Obviously, like 25% of cases usually have KRAS mutations, 23% have EGFR mutations, and then you can see there's a bunch of smaller mutations as well. And whether this be FISH or whether this be molecular testing, this is all stuff that is done in the pathology laboratory. So moving on, post-operatively, there's constant oozing that we're seeing from the surgical incision site, and now the hematology laboratory becomes involved, and the CBC shows that the hemoglobin is really low at 5.9 grams per deciliter, and the platelet count is very low at 29,000. And so now we move to the world of clinical pathology, or in some parts of the world, as it's known as laboratory medicine. And in clinical hematology, the blood is telling you the story. We can make a peripheral blood smear. We can do flow cytometry. We can give you the numbers. We can look at the cells. We can tell you if they are abnormal cells. And if they are abnormal cells, we can phenotype them and figure it out. So from leukemias to anemias to lymphomas, the clinical hematology laboratory is telling you all of that stuff. A patient could have an infection. And so the clinical microbiology laboratory tells you about blood cultures. We tell you about susceptibility. We tell you about kind of what bug it is. You know, we have incredibly fancy tools in these laboratories that are being used, right? And so in clinical chemistry, depending on the tubes that we receive, there are so many incredible things that we can tell, and we tell them actually pretty fast. And so a hospital course really cannot be completed without laboratory medicine, and it's a huge part of pathology. So what are we? You know, if we were to define ourselves, we are medical doctors who analyze human tissue and cells and body fluids, and we diagnose and help treat the patients, right? And so pathologists use microscopic examination and laboratory tests to gather information for accurate diagnosis, prognosis, and treatment. And as I've talked to you before about, we have AP and CP. You can go to the College of American Pathologists website. They have some incredible medical student related data. I'm part of the CAP's Future Pathologist Champion group, where we look at this. And so AP and CP is broadly defined as is on the slide. The timeline for training, for those of you who are medical students, it's 4 years of medical school. And then typically, depending on what you want to do, you can do 4 years of combined AP-CP residency, or you can do 3 years of AP only or 3 years of CP only. And usually it's a 1 year fellowship. It doesn't require an intern year. And most fellowships, you know, we have fellowships for pretty much everything, right? So all the subspecialties are represented. And if there is an aspect of healthcare that has a specialty, it has a pathology subspecialty in it. At the University of Michigan, we have 20 fellowships, and we don't actually have all of them. I think we're missing one. Okay. So I'm just saying that that's a lot of different subspecialties that you can be. So, for example, you can be a GI pathologist, you can be a hematopathologist, you can be a clinical chemist, you can become a medical microbiologist, you can do any of these subspecialties after doing pathology. The ACGME residency program requirements also include conducting at least 30 autopsies and examining and assessing at least 2,000 surgical pathology specimens. So for those of you who are in the match this year and like about to probably find out a bunch of interviews tomorrow because it's the interview release date, you know, you need to kind of make sure that the program that you go to allows you to do this number of stuff at least, right? Usually programs will have more than this, but this is the baseline, right? And so you should be able to be part of at least 200 intraoperative consultations, which is frozen sections, examine at least 1,500 cytologic specimens. And this is like throughout your time in residency, right? So it's over the 3 or 4 years. You have to be able to do a quality improvement project or a lab inspection, and then participate in research and do journal clubs, etc. This is a sample 4 year AP-CP residency schedule. I'm not going to spend any time on it, but basically all of the things that we were discussing in the previous slides, you have to kind of do as a pathology resident. And so I would like to say that you should choose pathology because it is challenging and rewarding. We're using our medical knowledge to identify and diagnose diseases. And really, I would say my chair at Loyola always used to say this, and Dr. Wojcik, and she said that healing begins with the right diagnosis. If you don't have the right diagnosis, you cannot cure the patient. We have pretty incredible work-life balance. I don't actually think that there's any such thing as a work-life balance. I think that you just have to try to get a work-life balance, but we actually have a great life. We use cutting edge tools and artificial intelligence. I mean, our laboratories are full of ancillary studies that are cutting edge, and AI will be one of our next tools. And I'm sure many of you will be thinking, oh, AI is going to replace pathologists, but it's not. I think it'll change the practice of pathology, but I don't think it'll replace pathology. We are, I would say, an integral part of a multidisciplinary team, and we contribute to advancements in science and medicine. So, our average salary, according to the 2021 Medscape Physician Compensation Report, was around $316,000 a year. We have, I would say, more than 11 subspecialties. Average pathologists work like just under 50 hours a week. 46% of practices, at least in 2019, were looking to hire pathologists. This goes up and down, but I would say last year there was a huge shortage of pathologists. Everybody was just getting the jobs that they wanted. And it is consistently among the top specialties for workplace happiness and amongst the lowest for burnout. So this is also AMA kind of data, like the numbers kind of fluctuate, but basically, we're not making as much as orthopedic surgery, but, we're not the lowest either. Do we feel fairly compensated? 67% of pathologists said that they do. I have to tell you that when they do data like this, I mean, I'm showing it to you, but like they don't really typically ask too many pathologists. And so take this with a grain of salt. I would say you should probably be talking to pathologists more than looking at this data. And would we choose the same specialty? 84% of people said yes. And I have to tell you that there's even a JAMA article where there's a lot of regret in a pathology kind of cohort. And it's the highest in regret. And that's a BS article because if you look at who they asked like five PGY2 pathology residents. And that's not the right, you really need to look at who it is. And so actually, Meredith Herman, who's one of my residents, and I are doing a paper with the American Board of Pathology to actually look at that data by properly asking a whole group of pathologists. And my guess is that it's not going to, like, I literally don't know any pathologist who regrets becoming a pathologist. So, so I think anyway, we are central to patient care. 70% of hospital decisions are based on path. We can have direct patient care through FNAs and apheresis and pathology review. There are many places now that are doing pathology clinics, which not many places. There are a few places that are doing pathology clinics, and that means that patients are meeting their pathologists. We are specialists. We have great cerebral and challenging lives, and we support research and education. 92% of physicians aged 35 or younger felt that work-life balance is important, obviously, and our work-life balance is actually pretty fantastic. So I would say that you don't get that much exposure in medical school. At the University of Michigan, we're very lucky because all of our medical students actually come for 1 week to do pathology, and then they can choose to do an elective. I would say, please, please, please choose to do an elective. I think it's very important for you to do that. When you are on a rotation, you might be allowed to do grossing, signing out cases, like looking at with the attending. Working up clinical laboratory tasks and autopsies and FNAs and bone marrow aspirates. And so it's a really hands-on kind of field. If you have not had exposure to pathology, follow a specimen, right? If you're in surgery, introduce yourself to the pathologist, join our organization. So College of American Pathologists and the American Society for Clinical Pathology both have free membership for medical students. So please become a member and look out for awards and grants and things that you can kind of be participating in. Virtual PathSeg is obviously a really great resource. Path Elective, be on social media for pathology. It's pretty great. Think about all the sorts of resources that are available to you. And if you are in the US and have the means to do so, try and attend a pathology meeting because it can be pretty great. So I will end by saying, do a pathology elective. Okay, that is the most important thing that you can do. It'll be important not only for you to figure out whether this is what you want to be doing in your life, but also it'll be important for you to get letters of recommendation. So with that, I will stop sharing my screen and I'm going to go through the chat to see what people were saying. But what time is it? Yeah, so that was 30 minutes in. And you have me for another 30 minutes. I can see some of you. It's nice to see you guys. But again, if anyone wants to kind of unmute and chat, Rasa's here too. We can kind of moderate, if you want to raise your hands and chat with me, I'm happy to do it. Was that okay, Rasa?
It was perfect, a perfect introduction. I just put in the chat, just going to tell you this. I actually, I know some people have already looked at it and laughed at the comment, but I was in, discerning my path to pathology. I was speaking to many different people at various stages of training, and I spoke to actually a friend's dad who is a pathologist in a commercial lab.
Yeah.
And so very high volume, high pay, but very high volume.
Yeah.
Um, And I asked him, if he regrets pathology, and he's like, pathology, no. Medicine, questionable. So
Yeah,
I don't, I
I
also
agree.
don't think I've ever met, anyone who regrets going into pathology. I hear that over and over again. I had also commented sometime prior, but the current neuropathologist, Heather Smith at Loyola, actually started as a neurosurgeon. And during
Yeah,
her PGY 1 year, she realized she actually doesn't really like the OR and liked
yeah.
understanding, the kind of rationale behind why these things are happening, which is how, you have pathology. That's what pathology really determines, the cause of the presentation of the patient. So I think for anyone who is really like intellectually curious and more looking to get at the mechanism of the pathology rather than just figuring out, okay, how do we treat these symptoms? Pathology I think is a great field. So I did get a message. Oh, I think it just disappeared maybe. Yeah, okay. So a message in the chat is what is important things that should be in my CV that increase my chance of pathology match?
All right, so let's talk about the match. So the pathology match has actually become, sorry, I'm sitting on a bench, so I'm going to move around a little bit. Uh, Pathology is actually becoming pretty competitive. And the reason it's competitive is not necessarily because a lot of people want to do it, even though a lot of people do. It's because there are not that many positions. Okay. So any institution will have like between four, like 3 to 10 positions per year. So numerically, it's pretty competitive. Okay. So, as a program director, I think that a couple of things that people want to look for in the CV. One is proper exposure to pathology, so that you need to have a story which proves to the program director that you've made an informed decision about path. And the reason for this is because historically there was this BS idea that, oh, if you don't do well in your steps or something, you should become a pathologist. I mean, that's the most bogus thing I've ever heard. Okay. Um, um, and and I have to say that that's kind of a really old school kind of thing which people have been propagating. And so a lot of people sometimes end up applying pathology as a backup. Okay. Like they want to apply for surgery, but they'll apply for pathology as a backup. We can pretty much see through that pretty quickly. And so I think that, your CV needs to be able to reflect that you've done a pathology experience and really want to do it. And so to answer Mohammed Al Noor's question, the things in your CV are obviously you need to have passed the steps. I think many places don't want, if you are a foreign medical graduate, I think that they want you to have graduated pretty recently. Like, some places don't like it when you graduate a long time ago. And then other than that, it should be some proper pathology experience. That means if you have pathology related publications, that's better than not having them. Doing research is not always a mandatory thing, but if you want to be competitive, then obviously having a publication is going to be helpful. For foreign medical graduates, it's also helpful to have some US clinical experience. I didn't have any US clinical experience when I applied, but I also did it like 15 years ago, so it's a little bit different now. Anyway, but I would say that your CV should be reflective of all of the experiences that you've been doing. And I'm answering questions now, so it's up to you. You have me for 25 more minutes, and so get those questions answered.
Yeah, for sure. I think you put it very well, and also, we have pathology programs kind of scattered all over the country, but certainly not as much as internal medicine, for example, or family medicine, where, there's like kind of a slew of programs. I think we have some concentration of pockets. There's like some programs here in the Midwest, on the East Coast, the West Coast, but looking at some other, more rural programs. I feel like pathology programs also tend to be more at like the academic institution, so that like limits it a little bit because again, looking at internal medicine or family medicine, you have a lot of community programs.
Yeah.
So there really isn't that like many programs. Like someone put in the chat, like there's a 632 PGY1 seats according to the 2021 match data. So I think it's kind of stable probably around that area. So yeah, it really isn't a lot. And you're correct in saying, of course, that you really should indicate your interest for pathology, primarily pathology, and like showcase that this isn't some sort of backup plan for you.
Yeah. Abu Bakr, thanks for putting in the 632 PGY1 starts. Do you know how many applicants there are this year? I think that data is already out there.
So I went through the NRMP data. It said that there were around 1,200 to 1,500 students that applied last year.
Right. So, so even if you average that, right? So let's say it's 1350, but it's for 600, like, and let's say there's 650 spots. So you can see that from that perspective, it becomes kind of competitive, right? And so just numerically, it's a competitive field. Last year, I think there was one unmatched spot, right? I think there was only one unmatched spot in all of the United States. So, that's a big deal. All right. So Basma's asking about CME. So Basma, I'm assuming you mean residency, kind of in another country, maybe, or what do you mean by CME? Sorry, I can't see you. I mean, I guess if you mean by CME, like, that you've been active in like kind of attending things, yeah, that's better than not doing anything, right? I mean, I think that when I try to answer these questions, I always say, if you're the program director and someone has graduated a year ago and they've done nothing in that year, will you want that person or will you want a person who's attended meetings or written something? I mean, it's not rocket science, right? Think about yourself. Like, you could all be program directors. So who would you choose for your program? The person who's more active or the person who hasn't done anything, right? And so, right. So CME credit, sure. I mean, I think that it's better than not getting it. And so I completely agree that, not everybody will be able to get clinical US clinical experience. But everyone who's been in medical school probably has access to a pathologist and probably can write up a case report or probably can do a review article or probably can get on social media and collaborate or attend, like, this session that with Kamran Mirza and,
Yeah.
kind of
Get
learn what to
involved with
do.
these,
Right.
virtual casting.
Exactly. Get involved with virtual PathSeg, right? I mean, these are the things that, I mean, listen, there's no magic formula. The match is a very, very fickle thing, okay? It's a very stressful thing and it's a very fickle thing. And so all you can do is you can work on every single aspect of your application and make it the strongest possible. All right. Uh, if it's a good idea to complete both step and level, Katie. All right. So I'm assuming that you're from an osteopathic program. I think that, I think that the jury is out. I'm not sure how all program directors do it, but I think one or the other is probably okay. I've heard of like a bunch of people taking step one as well as level one, and then only taking level like complex two, like not taking step two. So I think everybody does it differently. I think that when we look at your application, there is a converter, like a tool, and so we can kind of see what that number looks like. And so I'm not a big fan. I'm not a big fan of like people spending money and taking multiple tests, but I know that, to be competitive, you can kind of try to do whatever. All right, personal statement. So Leona is asking about personal statement without redundancy since programs are countless. Yeah, so I have to tell you the PathSig, match to path, PathSig, inside the match, all of these resources do personal statement related kind of online webinars, Leona. And so you should check. I'll try and find. Actually, if you just look for personal statement and inside the match, there's a whole session that I've done on the personal statement. And, it's free and the recording is available there. For many years, I've been doing it. And so I would say that in a nutshell, uh, but yeah, inside the match, exactly. I would say that in a nutshell, to answer your question, you want it to be you. So you don't have to be rehashing parts of your CV. I really want to know what makes you tick, right? I want to know kind of what makes you you, which is, and obviously you need to keep tying it to, pathology. Like it can't be completely irrelevant. But those aspects of your personality that make you a good team player, that will make you a strong resident, those are all kind of, aspects that you can have no matter what specialty you're going for. So I think it's important that you kind of convey a sense of your personality in it. This is becoming like a math session, which is fine. Totally cool. Any other questions?
Maybe you can just share a quick journey of what drew you to pathology and how you ended up in this career. I mean, I know the story, but I think it's quite interesting and maybe other people will relate.
Yeah, so I was confused about pathology and initially applied actually for two specialties together. Please don't tell anyone. I know it's being recorded, but I applied for pediatrics and for pathology and matched in a pathology program because I ranked all my pathology programs above the peds program. I had actually only ranked one peds program. And I lost that residency because of a visa delay and then ended up going to grad school and doing my PhD. It was a horrible time in my life. And the visa was like just delayed by a couple of days, long story. But either way, I lost the residency spot. They gave it to somebody else. And then when I was in my PhD, I realized that I thought that I'd really miss my patients, seeing them. And I thought, my romanticized idea of how medicine works was very much in a clinical setting, like in a patient-facing setting. And when I was in my PhD, I realized I actually don't miss my patients as much as I thought I would. And I found incredible amounts of satisfaction in being able to provide answers to people. So if you're in it for the glory, I'm telling you, no, pathologists never get the glory. No patient comes home and says, "Oh my God, I love my pathologist," right? So if you want like cards and chocolates delivered to your office that, patients are so grateful to you, it's not going to happen in pathology. It's unfortunate because it should be happening in pathology. However, it doesn't because the patient doesn't know that you exist. Okay. So if you're in it for the glory is different. The glory is very personal, it's very private. It's knowing driving home that you diagnosed a kid with leukemia, you gave them the right diagnosis, and now they're going to be treated properly and they will become okay, right? So I think that it's the privacy of knowing that you performed an autopsy and found an undiagnosed lesion and gave closure to the family, right? It is performing the thousands of CBCs a day and reporting on them because that is the machinery that keeps the hospital running. So it's not very glorious from a shiny perspective, but it's all very inner glorious. And so for me, that was my journey. I did not have an aha moment where I said, "Oh my goodness, it's pathology or nothing." Um, but I have never, even even on the most boring day, um, I have to say, I have never regretted becoming a pathologist. So that's a pretty big deal.
Yeah, that's wonderful. So someone just asked in the chat, I went through a lot of your videos
Yeah.
when I did my heme path rotation. What made you choose heme path? Do you regret to not choose a more anatomic subspecialty? And maybe you
Good.
can also talk about, whether you knew kind of going in
Yeah.
what you'd want to
Yeah.
subspecialize in and whether that's important for candidates too, is to have an inkling of a
Sure.
subspecialty.
That's a great question, Yu Ching. So I think that so going in, because my PhD was a lot to do with the lung, I worked on the lung vascular barrier. I was thinking I'll actually do thoracic pathology, and so which I actually did do. I did do a fellowship in thoracic pathology. When I was a resident, I kept an open mind, and I loved gynecological pathology. I was like, oh my God, I'm going to do gyn path, and then I went on my heme path rotation. And I fell in love with HemePath. It is just incredible. The ancillary test. So it is a perfect balance, I would say, of AP and CP. I agree with you that typically people don't think of it as an anatomical specialty, but we have lymph nodes and we have core biopsies, which is very much AP. We have smear cytology, which is very much cytopathology. So we really have AP. And then we have flow and we have molecular and we have hematology lab, which is very CP. So it's really, in my mind, the best of both worlds. Like nobody can argue with me on this. It really is the best of both worlds. I agree with you though that typically people think of it as CP and they don't think of it as AP, which is fine. There is this bias towards AP, which I think is kind of sus because like I think that we should be not biased about anything, but it is what it is. So I fell in love with the hematopoietic system because I had a teacher who made me fall in love with it. And I always say that you should never choose a subspecialty because of a person. Like you should never choose a subspecialty because you found a person who inspires you. But I actually did find HemePath that way, and you need to make sure that you continue to be inspired even if you're not with that person. And so the hematopoietic system is incredible. The number of cells we are making every day in our bone. Like in the last hour that we've been together, we've made like millions of cells. It's amazing. The cells are fantastic. My most favorite stain is a Giemsa. My most favorite cell is a megakaryocyte. I can keep going on and on and on. I love how we have the classification systems. I love how we use ancillary tools. I love how we can provide a very quick answer. I love how we can provide a prognosticated answer. I love the relationship we have with our hematologists. I love the relationship we have with our hematology pharmacists and the NPs. I just love HemePath. I love teaching HemePath. I love talking about HemePath. I love convincing people to do HemePath. So that's why I chose HemePath. Does that answer your question, Yuching?
Yes, I have same feeling. But
Oh, good.
when I do other subspecialty rotation, I I found that actually HemePath more rely on clinical pathology
Yeah.
side. So when I do DermPath, they actually diagnose under low power and
Yeah.
very fast. So it's very different. And so I can't really
Yeah, you're
decide.
right.
Yeah,
I mean,
yeah.
derm and GI are like very quick biopsy-based specialties, right? I mean, and heme does take time. And actually, I don't mind that. I think I would have been a good GI pathologist, but I think I would have missed something. I would because I'm very fast. So I think
Mhm.
I would have probably missed something. So I love that heme slows me down. I have to look at higher power. I have the flow cytometry. I have like a bunch of tools. It's kind of difficult to make a mistake in heme path, which I know that sounds like a weak way of saying it, but I actually like that too, that there's a lot of kind of other stuff that you can do.
So I have another question. If
Yeah,
there is no molecular pathology, molecular tools
yeah,
to help you decide if the cell is from a clone or not,
yeah,
is HemePath like still will HemePath still work?
yeah, 100%, 100%. I don't have the molecular results when I sign out heme path.
Okay.
I mean, we
Thank
get
you.
them in a couple of days, but I don't have any of them. I sign
Mhm.
out. So yeah, this is a very classic thing where I understand that in some cases molecular will change my diagnosis, which is fine. But yeah, it's very much a microscope based specialty.
Okay.
Yeah,
Thank you.
yeah. All right. So Sarah, I don't know how you pronounce your name, is asking, as a pathologist, how do you develop the confidence to make a final diagnosis as an OMS2? Still learning a lot of things. A concern of mine is providing an incorrect diet. That's such an incredible question, Sarah, and I love that you're thinking so deeply. But I'll answer your question indirectly. That is the same fear that you would have in any field, right? If you're going to become a surgeon, oh my God, what if I botch up a surgery? If you're going to become an anesthesiologist, oh my God, what if I give the wrong anesthesia? If you become a pediatrician, oh my goodness, what if I give the wrong vaccination? So in medicine, it is very scary when you're learning because you feel like you are going to mess up. And so you're right, even as a pathologist, like you don't want to give the wrong diagnosis, right? But that is why you have residency training and that is why you have fellowship training. And by the end of it, you need to be, if you go to a good institution that teaches you well, you will have the confidence to be able to practice. So I love that you're thinking about this, but I wouldn't let fear stand in your way, right? It's the time to learn, right? You're at MS2, so you have like 2 more years, I mean, incredible years of learning. So learn as much as you can so that when you come into residency, you are very, very quick at picking up new things, and then you can start becoming tactile and do procedures in pathology, etc. I think that you'll have a great time. But this is, even when I finished fellowship, I was a little nervous. I was like, oh my God, am I going to miss a diagnosis? It's very normal. And then at that point, you want to make sure that you are in a group, in a department which is supportive, okay, so that they support you and they give you support. I think that's a great question, Sarah.
How do you
So yeah.
recommend, Dr. Mirza,
Mhm.
people who maybe don't have a robust pathology department at their home
Yeah.
institution, how do you recommend that they get that hands-on exposure?
Yeah, you should. So if you are part of the what do you call it? The There's a group on the AMA, VSLO, VSLO. So if you're part of VSLO organizations, then you should look for VSLO based electives, right? Which are taking students from VSLO-based institutions. Otherwise, you can always write to pathologists and try and ask them to do observerships, etc. And I think that if you do have the benefit, VSLO, thank you, Masa. If you have the benefit of having a pathology department, introduce yourself. There will probably be a person who is the medical student representative. They need to get to know you so that they know that you're applying. Zara is applying to be a pulmonary pathologist. That's great. So I did a pulmonary pathology fellowship. Michigan has an incredible fellowship. Just keep it in mind. I think that your background as a pulmonologist will make you an incredible pulmonary pathologist, I think. And so to be successful, just work hard. You'll be fantastic. That's really cool. Basma, if we get an interview, what makes program coordinator choose us? Some things different than CV. Basma, it's every program director does things differently. At Michigan, we have a holistic review, and there's not one single factor that we're using. We're looking at a bunch of different factors. And so every institution will be different, and every institution will be reviewing things differently. I wish there was a magic answer that I could give you. I know how frustrating this time is, but I don't have an answer for you. I know that tomorrow a bunch of institutions are going to give out their interviews because it'll be the release date. So I wish you all who are in the match the best of luck. It's so nice to see all these names that I've never seen before. So this is really, really great. I hope that you guys are all on some sort of social media. If you are, please follow me and follow Patseg. I see Tia is here as well. Like, she's one of our leaders, and Rasa. Follow all of us, and this conversation can continue even afterwards. Hi, Tia. How are you?
Hi, doing well. Thank you. This was great.
Yeah, this is awesome. Yes, Abu Bakr, absolutely it would. I know you've messaged me as well. I think that being a cartoonist is great, and I think that should be part of your personal statement. And I think that that's a really incredible thing that I would like. If I was interviewing you, I would probably ask you only about that. Like, why did you do it? Do you have a company? Like, how is it managing people? Why does it give you joy? Like, there's so many questions that I can learn about you based on that. So yeah,
Frankly, I would
absolutely.
ask you to draw me.
Yeah,
Draw a little
exactly.
caricature on the spot.
Right? Yeah, exactly. I've seen your work on X as well. So yeah,
I actually drew the people I worked with
yeah,
on my last rotation, and they loved it.
that's
I did
good.
hand-drawn animations for them.
That's awesome. All right. So you have 6 more minutes. Okay.
Oh, we got a long one. Yeah, I'll
Yeah,
read it for you, Dr. Mirza. So,
yeah.
um, I am from Medina, Saudi Arabia, currently PGY1 resident in anatomical pathology. Just started my first month of training. One of my tutors recommended this meeting to me, encouraging me to explore the field of pathology from different perspectives. I'm happy to be here with all of you and feel even more fortunate to have started my journey as a pathology resident. I can really relate to your story as pathology wasn't on my list after graduation. I spent about a year postgraduate training in ORL and head and neck surgery. And during that time, I gained a deep appreciation for the crucial role pathology plays behind the scenes. Pathologists often don't get much recognition, but they're truly the backbone of diagnosis, the real diagnosticians guiding clinical decisions.
That's
Yeah,
really
thank you
great.
for that
Thank
insight
you,
for
Ragad.
sure.
Yeah, I never been to Medina before, but I went earlier this year, so I've been to your city. It's so beautiful and fantastical, and I'm really glad that you're doing a residency there. Thank you so much for joining. So Anna Marie, the things on the horizon really, I would say, are computational and AI based. I think that it will revolutionize how pathology is working. Many years ago, we didn't have special stains, we didn't have cytogenetics, we didn't have molecular genetics, we didn't have flow cyto, we had nothing. Okay, and pathology practice was still continuing. We were probably making some wrong diagnoses then, but that's okay. But now we have all of those tools. And I think the next step is that we will have computational pathology and AI assisted tools. And what that's going to do is it's going to make our diagnoses even more specific, even more prognosticated, even better, even faster. So I would say those are the changes that are on the horizon. Okay, Nadia's asking about mentorship and what things we should be looking for in identifying a mentor as a trainee, and what tips do you have to be a good mentor? So mentoring, so I have had the great privilege of mentoring a lot of people, and it's probably the best part of my professional existence. Okay. And I have to tell you that mentorship is very personal. Your mentor-mentee relationship, no two relationships are the same. I would say that you need to be able to go into a mentoring relationship with a very open mind. And you need to understand how the mentor and the like they both need to understand how each of them tick. Now, I think that mentorship meetings typically fail when mentees come to the relationship with an expectation of how they want to be mentored. And I think that you should keep an open mind because sometimes mentors may have something else in mind for you, but if you're not open to it, you're never going to learn from it. So obviously it should has to be in mutual respect. You have to kind of have some sort of metric for what the success looks like. And I think that in a mentor-mentee relationship, remember that the mentor is also learning from you, right? And so as I become older, my mentees become younger, and like well, they don't become younger, but they stay the same age, right, as they're going through. And I think I'm learning from my mentees, like, the things that are happening nowadays. And, I'm trying to reshape what I will say based on what the person's experience is. And so I would say there are some organized mentorship kind of opportunities through the CAP and the ASCP, and those are nice and they might work, they might not work. But I would say that if you have access to someone that you can email and get on a Zoom call with, I think those are probably the best types of mentorship opportunities that you should kind of benefit from. All right, 2 minutes left. One last question, if you have any. You're welcome, Nadia. You guys are so shy.
Yeah, I will say one more plug for our survey that I'm gonna put in the chat. So Taya doesn't come after me hunting. Please
Yeah.
fill it out if you can. It'll just take a couple of minutes. We really appreciate you guys joining today. I hope it was informative. Dr. Mirza is just such a game changer, in the field of pathology, really revolutionizing all of it for all of us. So I'm glad you all were able to kind of be in this space with him today. Follow him definitely on all of the social media platforms. He always shares a ton of great resources. And just connect with him. He is a phenomenal mentor. I can speak from personal experience. And yeah, just, again, thank you for being here and best of luck to everyone tomorrow. Universal interview release date. I hope you all get all the interviews that you want. I hope everyone ends up in the program of their dreams and that we're all amazing colleagues, future pathologists in the future. So thank you all
Wonderful.
for joining and thank you so much, Dr. Mirza.
Thank you, everyone. Good luck.
Have a great night. Hey, are you excited for tomorrow? Scared? Wait, are you not applying? You
No,
did a,
no, I'm not this cycle,
why did
so
I?
I'm resting easy
Oh, that's
tonight.
good. Yeah.
No, oh, that's so exciting though.
It is exciting. I think it's just kind of like, I feel like the chaos is going to hit like all at once because I think they set a time for like 3 p.m. I low-key kind of hope some programs send it a little bit early, like just so that it's not like all at once.
Yeah,
I did get a couple interviews already for the physician scientist training programs because they're
got it.
kind of like like Northwestern, it follows the universal interview release date. But
Mhm.
like for PSTP, they just have to like arrange it differently. So they did extend that. I got one from Michigan today for their
Oh,
PSTP. Yeah. So, but yeah, I mean, I'm curious to see what happens tomorrow, all of the
yeah.
chaos and the scheduling.
Yeah. Well,
Ready
at
for
least I guess it's nice to know when it's coming rather
yeah,
than it be
sure.
like the drops.
100%. And I think it's also nice to, I admittedly like over applied. At least like that's what I've been told I did. It doesn't feel like, I applied to 24 total programs. So it doesn't feel like over applying, but I think it's just because I'm so like niche, and with a PhD, it's just like a little bit different. Um, and so it'll be nice to kind of see all of the programs laid out because like very realistically, like when I was thinking about it, I was like, oh, 24 is not that bad. But if you like try to actually put 24 interviews in, like that's a lot, right? Because you're
Yeah.
not, no one's doing interviews on weekends. So you're like really like that's a lot. So
Yeah.
it'll be nice to kind of like have it laid out and then also think like, okay, like if it becomes too much, like being like, well, maybe like this is a program that I like don't necessarily want to live at or whatever.
Hmm.
And be able to like decline that and make sure that someone else gets, the opportunity to have that spot instead. So
Yeah.
yeah, so it'll be
No,
exciting,
definitely.
exciting times.
Oh,
But
yeah.
yeah,
Some are they in person now interviews again? Oh,
no,
oh,
they're all
okay.
virtual, at least like
Okay.
so I've gotten the two PSTPs and then I got Hopkins early last week. No, the week before. And they've all been virtual. So
Oh,
in general, I would think that because from my experience in recent years with other MD PhD grads, PSTP interviews sometimes are in person. And
hmm.
so if the PSTPs I received so far are virtual, I would guess all of them are probably going to be virtual. Uh,
Yeah.
yeah, just because I wouldn't necessarily see like the need for it. But yeah, it'll be interesting. I don't know. I just need to like gather, I feel like more information about all of these programs uh to like know really like what I want because all of them seem so great. There's lots of great programs and it's tough too because like Michigan is like Dr. Mirza is like the
Yeah.
best. Um and I'd be able to have like I was talking to Lauren Miller and this weekend and like she owns a 4-bedroom house on like an acre and like that is the life that you can have if you live in Michigan
No, it
versus
is nice. I actually really like Ann Arbor. Like I have a few friends that went there
oh that's
for
awesome
undergrad, and
yeah
it's just like it's a really like nice and like homey place, I feel like.
yeah so I've never been to Ann Arbor but I went to UW-Madison for undergrad and I heard that
Got
it's
it.
like basically the same
Yeah.
and we loved Madison. We loved living in Madison. So, yeah, so I don't know. We'll see. We'll see kind of how things shake out. It's really hard to know, before you do the interviews. And I talked to Colin about this extensively too. And he has this like, and Lauren apparently did too, but Colin sent me his like ranking spreadsheet and it's like actually absurd. Like he even like calculated the number of days of sun during for like each location. Like so he factored in like all of the factors, but he was like at the end, like the numerical scores actually just matched up with like the general like feeling that I got about the
Yeah.
program. So I'm hoping that it kind of is the same for me, where I can like at the end of the day just say like, oh, this is like where I feel I would be
Yeah.
best, like would be my best fit. Because I think like, you know, if you would have asked me like a few years ago, maybe I would have told you like, oh, just like go to the top program. But like it's very like the top program is like a very subjective, I feel like,
Yeah.
thing because you have all of these rankings and generally, especially when I think there's like, okay, there's top programs, there's like mid-tier and there's like maybe lower tier programs. But when you're like in one of those categories, like they all blend in. You can't be like, oh, this
Yeah.
program is number one versus this one. And so you do have to like just probably go with the feeling of like what is best for you actually subjectively. But
Yeah. No,
yeah,
makes sense. Lots to feel
no,
out, lots to
yeah,
figure out.
yeah. So I think for this meeting, I put it in the spreadsheet of our like meeting thing attendance.
Mhm.
I saw that. I can share it in our board chat because I see that they didn't fill it out for the PD panel, the registration numbers and like attendance and stuff.
Yeah.
So they'll just have to enter that. But we had like 60 registrants and 31 came total. So like I feel like that's pretty good, like half.
Yeah,
Yeah,
I feel like that's really good, especially for like a non like residency
non-match.
application
Yeah,
event.
yeah,
I think
exactly.
it was actually like quite a good turnout.
I agree. I agree. So yeah, I'm looking forward to like more things this year. And what do we have on the calendar next? Do you remember for November?
I think it might be Claire's journal club.
Journal
Yeah, I
club.
think it is Chair Claire's journal club.
Okay. Yeah, so we'll see how
Yeah,
that
for
goes because we
November.
haven't done that before, right? For V.
No, we
Yeah,
haven't. I think like the big question will be whether to get a resident or
yeah,
to help moderate and figure out the format.
for sure, for sure. Yeah, it'll be like interesting to think about how to structure this to have like maximal engagement of the
Yeah.
participants because journal club really should be more of like a discussion rather than just like, oh, present the findings. Um, but that can be a little bit tricky, I feel like, to do. Certainly, you want people to have read the material, or I don't know. Yeah, we'll see how like that shakes out. It'll be a pilot. If only us show up, that's fine. Like that's no big deal. But yeah. Okay, so I'm gonna hop
Okay.
off. Hopefully, we got people to fill out the survey. I put it in the chat more times than I can count it.
Yeah, no, I saw. I appreciate it. Thank you.
Of course.
There it is.
All right. Yeah.
Yeah.
Have a great night, Taya.
All right, you too.
Bye.
Bye.